again, thank you everyone for being here. So I will first introduce myself. So I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, so the European Reference Network on Rare Haematological Disease. And indeed, it's my really great pleasure to welcome all of you on behalf of the ERN. So as you may know, today is the third session of a webinar program, a comprehensive one, that is foreseen in the framework of ENROL, so the European Rare Blood Disorder Platform. And as said also in last session, this program has been co-designed with the ENROL consortium. We are going to present it. And within this consortium and within the organization of this program, we are very happy to say that we had also the contribution and the co-designation of our ePAGs, so the patients, the European patients that together with the EURORDIS contribute to our initiative in the ERN. And they are indeed part of the ENROL Steering Committee. On the last two webinars, we had the occasion to talk about the ENROL, how it is structured, the policy of ENROL, the adherence of ENROL to the European rare disease. And also on the second webinar, we saw how registry can support clinical research and patient-centric research. And today we are going to focalize more on PROMs and PREMs. We are going to discover what they are and know more our PROMs are related with registry and ENROL. As always, we perform those patients webinar with the Dubow. So I'm really glad to have together with me today Jacqueline Dubow. So Jacqueline, would you mind to introduce yourself, please, as today we are doing moderation and speaker together.
So hi everybody, I'm Jacqueline Dubow. I'm an ePAG within the ERN-EuroBloodNet. I'm the chair of the MDS Alliance, which is an umbrella group with over 40 association within the world, and I'm a member of Connaître, Combattre, les Myélodisplasies, which is the MDS association in France.
Thank you very much, Jacqueline. Okay, so I guess you are all seeing properly the PowerPoint. Well, I have already introduced the topic of this webinar and the two speakers, so me and Jacqueline. This is the consortium overall. It has been already presented. So as you can see, it's really a consortium that is across European one, and it's also enrolled by the endorsed by the European Hematology Association and EURORDIS too. What we saw in past webinar, I have already mentioned it very quickly, but if you want to see it more in details, we understood what a registry is. So it's a platform that collect patient data like country, disease, age, treatments, and among other items. What does ENROL? ENROL maps all the common data that comes among those existing registry dedicated to rare hematological disease in Europe, in order to facilitate the monitoring of a disease in Europe and in order to provide results for research and also for policy making. How ENROL do that? So ENROL gather data that in Europe would have been fragmented in several registries in one centralized platform, and makes those data understandable, accessible, and also reusable by researchers and policymakers. Of course, guarantee patient privacy. And also, we saw how registry are also a great support for research and patient-centric research. And as said, you will have the possibility to follow those sessions if you miss them following the videos. And so, Jacqueline, in this new webinar, what we are going to learn?
Okay, we are going to learn what PROMs and PREMs are and what are the benefits that are associated to them within registries. So mainly what we are going to follow is first definition, what are PROMs and PREMs. You've heard, we all talk about quality of life, but behind quality of life, how do we measure it? We measure it through PROMs and PREMs. Then we are going to see what are the benefits for using them for patient and the scientific community. The third part will be, what do we need to know about PREMs and PROMs before including them into a registry? PROMs and PREMs are scientific tools, so they cannot use like we want. There are some rules, validity rules that are very important. And then we move to where can we find adequate PROMs and PREMs questionnaire, and where could I get in order to get more information on PROMs and PREMs. And last, how to use PROMs and PREMs for advocacy, which is quite important for patient association. So what are PREMs and PROMs? Mariangela, it's up to you.
Yeah, thank you. So before coming to the definition, I wanted to share with you this example, which are really disclosure had been completed, invented. So take it like an example. So let's imagine that we have a clinical trial on a drug that helps for increasing the hemoglobin level. So we have from one side the patient point of view and the physician point of view. So the patients, of course, need to have an increasing of hemoglobin. And so he feels symptoms like fatigue, weakness, pale skin and gums, shortness of breath. He has a fast of irregular heartbeat, and the physician say hemoglobin 6. Then with this new drug, symptoms change. And so we have a physician, they say hemoglobin 14, so we can see an increasing, but the patient still feel some of the mentioned symptoms like fatigue and weakness. So what will be the perception? Will be that the physician say hemoglobin 14, the drug is working, and instead the patient would wonder if the drug is working because he still feel weakness and he still feel a lot of fatigue.
And then we have another example, why perception matters. And here we are talking about the patient perception, but I want to give you the example of the study that was done in France in 2020, and it was on blood transfusion burden. And among the questions that were asked to MDs, hematologists, nurses in the middle, and patients on the right, the question was, what happened to you when a blood transfusion is done in a room with other patients? Because in some cases, you have a nice hospital where the patient can get a blood transfusion in a private room, but most of the time, the patient needs to share the room with other patients. And the question was, it's reassuring, that's the first line. And you can see already a difference. In dark blue, it means strongly agree. In lighter blue, it's agree somewhat. And here on the agree somewhat, you have 55% of the MDs who are thinking that it's reassuring for the patient, but among the patients, it's only 30%. And with the nurses, the response is closer to what the hematologists are seeing. Then, is sharing a room with other patients is bothering you? For the MDs, 38% think that somehow it's bothering the patient, but only 15% of the nurses think it's bothering, when 70% of the patient think it's bothering. So here you see the perception from the nurse matching better the perception of the patient. And then the third question was, sharing a room with other patients makes the patient stressed, anxious. And here it's quite amazing, because you have 30% of the MDs who think that somewhere, yeah, it makes the patient more anxious. Nurses, only 15%, it's more reassuring. Patients, 5%. So clearly, patients, if they share a room with other patients for blood transfusion, are not anxious, when MDs think they are anxious. So those differences of perception are very important. You can see it through that slide, and it's very important to collect them. So, Mariangela.
Yes, thank you, Jacqueline. So the question is how to integrate the perception of the patient into the clinical outcome of the trial.
So, what are PREMs and PROMs? I'm starting right away by saying that they both start with a P. That means patient. And both are done from a patient perspective. The patient, the reported outcomes are measuring the efficacy of healthcare. It detects problems, it increases communication, it helps to get better shared decision. It measures impact, the outcomes. That's what it means. And it's always self-reported from the patient through an interview or through a questionnaire.
Thank you, Jacqueline. So we can also see that there are different kinds of these PROMs that are clinical outcome assessment. And as Jacqueline said, what determines the different kind is the perspective and point of view of what that is rated. I'm going to explain it better. So we can have PROM that are patient-reported outcome measure. So it's the patients that answer those questionnaires. We can have an OBSRO, that means observer-reported outcomes. So it's a caregiver that observe the patients that answer the questionnaire. Those can be useful in the case of pediatric patients, or for instance, patients affected by neurological disease or cognitive disease. Then we have clinician-reported outcome. So this is less patient-centric, but is the physician that report the questionnaire. Or we can have a performance-reported outcome. So the patients do a performance, like if we imagine some questionnaire for mobility troubles, this is one of the tools that can be used. We can now see the structure. We have the example of a questionnaire on dermatology, which could be used, for instance, if we think about our hematological disease in cutaneous lymphoma. And so we have the structure, which includes first an instructions. in the structure. So here we can see the aim of this questionnaire is to measure how much your skin problem has affected your life over the last week. And then the instruction, please tick on box for each question. Then we have the item, which is the question that contains the concept and the period. Because you can imagine that those questionnaires are systematically collected, as it could be dedicated to a lifelong condition or a transition condition that we want to assess the before and after. So it's usually they are not one-shot questionnaire. So here is over the last week, how itchy, sore, painful, or stinging has your skin been? Then we have the response option, very much, a lot, a little, not a lot. And finally, the response option with a number, so the score just shown. And also what is important on the PROMs is that they arrive, well, we explain it, they also assess the qualitative research and qualitative results. So we can see the domains covered by the questionnaire, like function, patient feeling, patient perception. And indeed here we see in this example, symptoms and feeling, daily activity, leisure, work and school perception, personal relationship, and treatment. So the area could be really huge. And the FDA in 2009 has published a guidance of the PROM development. It usually goes from 1 year to 3 years, and it has 3 phases that I'm going to show you. So the first is the item generation, so the identification of the what need to be measured and the question related. So of course the researchers that are working on it together with patients and clinicians do a literature review, then do an interview to patients for understanding what is important for patients, also what is important from clinicians, so they can match the patient perception and perspective with the clinical needs. And then they created a list of preliminary items. On the second phase, you can imagine we have a test. So we can assess how the group of patients that have been selected for the test understand the question. So are they understandable? Then the first rates are analyzed to see if the statistics make sense. And then eventually, if some questions are not understandable, for instance, or if there are no cohort or final score that can be identified as variable and biased, we can think about modify the PROMs for having a better result of the objective. And the third phase is really the validation that show that PROM is valid, reliable, and also easily understandable and easily performed. And as said, it takes from 1 year to 3 years. So it's a very long procedure. And here we arrive to the definition of PREMs. Jacqueline, do you want to introduce them?
Yeah, PREMs are slightly different because they are measuring the experience, the perception of the experience of the patient regarding the quality of care and when is receiving the care. And PREMs are not looking at impact of care, but they are looking at the experience of the patient. And what's very important here is several studies have shown that patients that are getting PREMs questionnaire during a clinical trial or during a treatment show much better adherence to treatment, because when you let the patient expressing his or her feeling, there is better communication, and both sides, the caregiver and the patient, try to work together much better. So PREM structure, it's more or less the same. You know, you first have the instructions and clearly what is the question, the overall question of those PREMs. Then you have the question, for example, how long do you usually wait for a transfusion to be set up? Then you have the response and the different options in terms of time, because timing when a patient receives a treatment is quite important because it may change the outcomes. And then you may have also some score to give. Is it easy, difficult, available, very difficult? What do we need to know about PROMs and PREMs when we want to include them into a registry? So Mariangela, give you the floor.
Thank you. So we saw a little bit already the validation process. So first of all, we need to know what to measure. So what do we need to hear from patients? And it could be, for instance, that the patients describe the disease burden, so something related with quality of life, that the patients, as you just explained, Jacqueline, assess the quality of care, so more with the PREMs, that the patients evaluate the treatment impact, so in terms of side effect or feeling or functioning, and also that the patients express the perception of the change in symptoms. Are they, have they getting a better quality of life thanks to better expression of the symptoms or not? Then we need to fix also an objective. So what for? We want to hear this, but for using how to use them. And indeed, PROMs and PREMs can be used, as you can see, in a wide range of clinical area that could go from patient management, so provide guidance to physician and dissemination the current education and knowledge to physician, for supporting medical decision-making tool, for instance, like deciding among one drug or the other, strengthening, so helping the communication among patients and physicians. I have, for instance, I can bring you this example. I have recently participated to a workshop on this topic for a disease that causes a lot of painful crises, and I've realized how difficult it is for patients expressing the definition of pain they are feeling, and for physicians to understand the pain, because, for instance, in chronic disease, people are, into bracket, used to pain. So you can see people laughing, but they are in pain, and the physician could think he's in pain, he's laughing. So it could help this kind of questionnaire of giving an understanding of really subjective perception like pain. Then they can be used in healthcare management for evaluating the efficacy of care in the practice, or, as said, in clinical research. So for evaluating the effect of a device, a surgery, a care, a drug. And of course, also the context of use is very important to be identified. Here we have, for instance, different questionnaires that are dedicated to depression, which is unlikely, how can I say, a common effect of a disease. And so we can see that we have different questionnaire for the same measure of depression, but one can be screening anxiety and depression in hospitalization. The other could be the assessment of program for measure the impact of the depression. Then we can have assessment of midterm outcomes of care of all patients from hospital, or assessment of intervention.
So in a nutshell, what we've been describing is the first step is to define. We need to define the objective. We need to define what we want to measure through PROMs or PREMs, or sometimes both. And we need to define the context of use for PREMs and PROMs. Then we need to search for the right PROMs and the right PREMs. Some already exist. If you need to create them and to validate them, as Mariangela said, it may take up to 2 years. Then when you have your right PROMs and PREMs, you need to select the one you want, and you need to measure what you want to measure. And matching, and that's very important, you need to match your objective with the context of use. Because if your objective is too large and doesn't fit within a context, it's not going to be very useful. And then, last step, you need to identify what are the further validation steps. And those are important also because PREMs and PROMs needs to be scientific tools measuring what we generally do not measure: the patient expressing himself. So what are the criteria to accept patient and physician, for patient and physician to accept those questionnaires? They need to be feasible. That's common sense. They should be easy to use. And here we are having some problems because often PROMs and PREMs are not always easy to use. If I take an example for myelodysplasia, the QOL that is being used has 38 questions, and it takes close to 40 minutes to fill it, and that's really too long. So easy to use is very important, but it's not always the case. They need to be actionable, and the results needs to be attached to a decision or an action. It can be in a clinical setting. Let's decide to have blood transfusion mainly in the morning and avoid them late afternoon. That's a decision. They should be in a context, and they need to be incorporated in the routine process of care. We need to see an application, if I try to say it in a more mundane way. And they need, of course, to be useful because they need to improve healthcare. They need to improve the communication between patient and professional and MDs. So beyond the PROMs, the validity of those PREMs and PROMs, the acceptance from both patient and clinician is critical, because if there is no acceptance, it's not going to work. And it's very important to have an early patient engagement in all of those activities. That's what patient associations are requesting. often. And because sometimes things are changing now, but up till a recent time, patients were arriving at the end of the process. They were still the object of the research when they need to be part of the research. So why PROMs data are very important for advocacy? Sorry, I'm saying very important. I should.
It is very important.
But it is.
It's even crucial.
So, up to you, Maria.
Thank you. But it is, indeed, we need to stress it more. Why those are important? Those are really useful tools in the hands of patients' association, patient advocates, because they provide evidence. They not just express need or burdens that the patient feel, they provide in a systematic way scientific evidence of the patient perspection. So here we can see some examples. From one side, we have the patient community expressing need and burdens based on their experience and feeling. And the other, we are going to see how the community can express needs and burdens based on their experience gathered through those systematic tools that are questionnaires. And so now Jacqueline is going to show us some examples that are issued from this questionnaire. That is, it's also focused on transfusion.
Yeah, those examples are more or less the same. You know, at the beginning, you have the objective, then you have the different type of question about the patient. Next slide. And among the results, you have, it's coming from the patient expressing the fact that they spend a lot of time when they need to receive a transfusion. And a lot of patients are young adults, they are still at school, or they are adults who are working. So the transfusion needs to be done in a timely manner and in a manner that is convenient for the patient when he is available. Because in some countries, if someone needs to be at the hospital for one day, they may not receive any payment, any salary. So majority, in that case, the majority of the responders, almost 64% are transfused in the morning. And during the weekend, it goes down because they are not supposed to be. But we see that a good number is also transfused in the afternoon. So next slide. And so among the patients who are transfused in the morning, 30% are working full-time, 13% are working part-time, and 21% are not working. So that's what we have. And people express the right to work, to be able to work. So there is a need for adjusting those transfusions to a time that is convenient for the patient, and not the opposite, because too often in healthcare settings, the healthcare setting is predominant to make decision, and the patient is still the object of the care. Here, we try to reverse and to have patients saying, we need to have our blood transfusion when it's not going to disturb our school time or our work time. So, Maria, up to you.
Thank you, Jacqueline. And indeed, on the same example, I mean, taken from the same questionnaire that was performed among thalassemmic patients or transfusion-dependent patients, we can see that a patient or a patient community can express, my center doesn't guarantee me a good adherence to the treatment. I experience a lot of pain, which is, of course, a very important matter that is expressed from the patient. But if we gather this perspective in a questionnaire, what they can say is evidences like of 126 patients who claimed regularly taking medication and being treated in specialized centers, those were, well, the most of them, so the 62%, while the 27% were followed in other departments, so not in expert center. And in this cohort of patients, almost 33% were receiving the proper drug, while the other were on a combination of the subcutaneous drug and oral chelators. So more than a half still had to adhere to the treatment and had experience on pain. So the need can be claimed providing evidence. So the need is to adherence to lifelong treatment that requires support from the healthcare provider, and they can provide data that support these needs. And so they have quantitative evidence that could be used for shaping health planning or health delivery in centers. So the centers can have those services available if before they had not, because the patient's community provide to the policy-making decision that this service is really crucial for us because, and those are the data.
So in the registries, now you understand why PROMs and PREMs are important to provide data, because registries need to have a clinical information. Yes, that was the original goal, but we need to be much more holistic and integrate the voice of the patient. And for example, in those, in those registries, you can have information about daily activities, symptoms and feeling, personal relationship, things that were not included before into registries. So the systematic gathering of evidence via registries needs to associate PROMs and PREMs. And they need to be used for advocacy. That's a very robust tool. And I'm using the word robust because those are validated. I mean, it's not the usual feeling approach that maybe are used by the media, for example. By using those evidence, you are bringing solid data. So the medical community is going to listen to you. And it helps also to determine if a clinical service has a good standard of care. For example, in France now, the Haute Autorité de Santé, which is the main body for healthcare in France, has been using those PROMs for several years. And when you have minor surgery or major surgery, you are asked to fill one of those questionnaires. They are all put together. I mean, the response are all put together, and it helps the Haute Autorité de Santé to do a ranking of healthcare centers, and they are graded. And it's quite good because it increases some competition between the different places. And of course, PROMs and PREMs recognize that people with disabilities, people who have impairment or are handicapped, have the right to express themselves, and they need to express themselves. So in a nutshell, what are the challenges for those PROMs within the rare disease environment? First, we have scattered knowledge and expertise on rare disease. We all know that. The knowledge is everywhere, and because those diseases affect a few number of people, there is little expertise. There is a lack of knowledge on PROMs that exist and that are accessible because they have not been used. So there is not enough knowledge among the medical profession regarding where to find those PROMs. There is also a lack of a rare disease patient association. They are not, I wouldn't say exactly a lack, but they are not involved enough because they have a lot of knowledge, but they need to learn how to validate those knowledge through PREMs and PROMs. Then there is a lack of background knowledge and time on how to develop and validate PROM. So here that's an issue because time for developing and validating PROMs is big. And there is also a lack of basic and clinical research for rare disease. We all know that, and that's why we are all working together through the ERN. And last, there is a lack of validation standard and lack of reporting. Validation standards are really complicated because for clinical trial, you absolutely need to have PREMs or PROMs that are validated, and not so many have been validated. And then lack of reporting. There is a group that looks at reporting of clinical trial, for example, and PREMs and PROMs, and it's very true that if some countries are very good for reporting, some countries are not very good. So those, that's a more general challenge, but it also needs to be addressed. So now, where could I find the PROMs and the PREMs that I really need?
Yes, so I'm very happy to present this project that is within the ERICA, so the European Rare Disease Research Coordination and Supporting Action. Is linked to the Working Package 3 that has created a repository of validated and existing PROMs and PREMs for rare diseases. And of course, this is a way for facilitating all these burdens that you just described, Jacqueline. So I'm happy to be part of this fantastic team that, as you can see, is made by not just the ERN-EuroBloodNet, but also Orphanet and the MAPI Research Trust. And for saying it in a nutshell, there is this repository on the ERICA webpage. I will show you the link, that has been nourished by several exercises The first one has been identify rare disease PROMs in the PROCOLID, that is a database for clinical outcome assessment. And then we have performed a survey among ERNs, including Patients Association, all ERNs, not just ERN-EuroBloodNet. And as a result of this true exercise, we have identified a first list of PROMs for rare disease, almost 800, and also OBSTRO, so those observer reported outcomes, will be in the next week included in the repository, and 15 of them are specifically developed for rare disease, because of course in this repository you also have generic quality of life that could be applied to frequent disease or rare disease. This is how the repository look like. You have here the link, then I can put the link in the chat. But by the way, if you write on Google, Erica Working Package Stream PROMs repository, you will jump into this repository. Here we have an example. I just wrote transfusion, and here I can see some questionnaire related to this service. And you can see here we have the name of the PROM, the type. So if it's that the patients, I need the patient perspection, the caregiver perspection, the performance perspection, the age, is it adult, pediatric, aging, and so on. The domain, here I can read the tiredness, weakness. So the disease, in this case, both are for beta thalassemia, the ORFA code, the group of disease or rare anemias, and the related ERNs, and where available, we have also the link to the PROCOLID. Then you can click on these prompts and you have further information, like healthcare information, condition of use, translation, population, and all the relevant information. If you are ERICA members or ERN members, including Patients Association, you can request the access to Marie Murel. You have the email there. So, in a nutshell, we are at the conclusion and taking home message. We have seen that systematic gathering of evidence via registry associating to PROMs and PREMs could be a very important tool, not just for research, but also for raising patient needs. And I'm going to show you now an example that is taken from our ERN. So from one quality of life studies, we have seen that quality of life in sickle cell disease patients could be considered as poor, both in children and adults. You have here on your left of the screen the studies, and those is perceived as similar or even worse of cancer patients on treatment. And indeed, vaso-occlusive pain crises are the hallmark of this disease, the sickle cell disease, and the primary reason for healthcare utilization. And guidelines indeed recommend aggressive intravenous opioid, intravenous fluid, and anti-inflammatory therapy as the mainstay of treatment for acute sickle cell disease pain at emergency room, hospitalization, admission. However, many vaso-occlusive crises are managed at home with oral medication and supportive care, which are not captured in the endpoint. Of course, they are not so severe in principle, but still. So the lack of guidelines on home medication management of sickle cell disease-related pain, together with the growing concern for opioid abuse and misuse, results in importance, so a difference in outpatient pain management. And also we can see that the social environment or the education, the racial, the cultural, the economical barriers also impact in this quality of medical attention received and demanded, and on the self-management of the patients. So from those studies, we can see that vaso-occlusive pain crises require hospital admission as an endpoint, but it's not sufficient and accurate enough to assess effect of drugs or genetic modifiers. So those are eligible criteria for drugs that should contemplate management of crisis at home. So the conclusion is that we need really validated tools as PROMs and PREMs implemented in the ERN registry as part of the medical visit, or ideally, we can imagine them through application on the phones that can be answered by patients. And so they can be captured in the registries and used as source of common data and source of data in research. Thank you very much. So this was our conclusion. For breaking the ice, before going to your question, I want to ask, because I know you are studying this a lot, Jacqueline. Indeed, one of the burden of the PROMs, we have mentioned it, but I want to underline, is that the analysis of the data could be time consuming, because those are systematically questionnaires that could be performed at every consultation, or can be performed once per week, one per month. So of course, sometimes clinical communities say it's really time consuming to have those, the results and the gathering of the data through PROMs. So do you have a view on this big burden on the administration and use of PROMs?
Yeah, what is happening right now is, of course, the use of big data and artificial intelligence, because all the time that is required to look at the result, it's not quantified here, but it takes weeks and months. And the use of big data is bringing the possibility of getting results already almost in real time. So you can imagine that if the results are coming in real time, they are more likely to be applied. And if we were talking about the criteria for using, for acceptance, feasibility, actionability, in context, useful. That's where the use of machine learning and artificial intelligence is important, because it makes all those criteria feasible. And there are already experience on crossing data from many different PREMs and PROMs, which manually would be a huge task. And there is so much to be learned from that. Being able to look at, for example, PROMs related to a specific rare disease. So that's one thing. The other thing is the natural language processing, which is the ability by a machine to understand the semantic of the language. Progress are huge. You've all heard about ChatGPT, and it's just the beginning. And at one point, it will be possible not to have written questionnaire, but just to have oral questionnaire. And it's much easier for a patient to respond to an oral questionnaire, because here, what the natural language processing will be able to capture, which is not captured within PREMs and PROMs, is how the patient is. Does it make pauses? Does it using a higher pitch where you can feel that there is some anxiety? The PREMs and PROMs are capturing part of it, but not all of it. So here we have tools coming that are going to make those PREMs and PROMs much more easier to apply and much more efficient in terms of impact. And I think it will come soon. It's a question of 1 year, 2 years, maybe less, I don't know, but it will come.
And we cross the fingers. It will really come soon. Thank you very much, Jacqueline. I'm addressing some comment in the chat, but as said before, don't hesitate to take the floor if you want to express also yourself orally. So Miriam says, thank you for such a good presentation. Thank you very much, Miriam. Excellent example, and so true that the patient is often the object of treatment and not really the focus of treatment decision. Indeed, we really wanted to provide this perspective. And then Mariette also provides some link, thank you, to PubMed, with one harmonizing patient-reported outcome measurement in a inherited bleeding disorder with PROMIS, and then also a development of a standard set of PROs and generic PROMs for Dutch medical specialist care, recommendation from the outcome-based healthcare program working group. Thank you very much. You have the link in the chat for the rest of the audience. Then
shall I add some
please.
comments?
Please.
Hi, thank you for the excellent webinar. I think it's really great to inform our communities in this way. Yeah, I'm really struggling, you know, to try and connect what is happening at the national level with what is happening in the ERNs, and that's why I provided at least these 2 papers, since we will have a generic set of core outcomes for chronically ill people in the Netherlands that will hopefully be start to collect it in hospital care, in the next year or so. So let's see how that develops. And for the bleeding disorders in the Netherlands, we're really validating also core PROMs, and that is the second paper. And I hope at some point we will be more intensively working with EuroBloodNet, because I think this is the future, and to have really data collection on a European level. So let's see how we will be able to do that. But we will be discussing. Thank you.
To you, thank you very much. And indeed, we have a common objective, and it was also one of our wish was to show what could be achieved with the ERN, the registry, the collection of data, but also through patient advocacy. So it should be a conjoint action. And I, as you, Marietta, will also encourage it as much as possible. Thank you very much. So then I see a lot of good feedback. Thank you. It really means a lot for me and Jacqueline. Thank you. And I don't know if you have any other question. We are there for answering if you wish. If not, we will say have a nice evening to everyone. So we'll see. Thanks to all of you. I hope you enjoyed these 3 sessions dedicated to registry. And so have a nice evening. Thanks to all of you.
Thank you. Bye.
Nice evening. Bye. Bye.
Bye and thank you.